Welcome back. Oh, hold on. Welcome back to your FDS Friday workshop. So yay, exciting. We have some amazing speakers for this talk. That sounds like a really practical and useful topic. I'll let our speakers introduce themselves. Just remember to, I just want to encourage people to chat smaller groups here on these FDS Fridays in general. And so we're just trying to make sure that we can keep our communications going. So please feel free to chat.
Perfect. Thank you, Tammy. I'm just pulling up the slides right now. Can I get a thumbs up or a signal that people can see them?
Looks great.
We're good? Okay, good. So good afternoon. Thank you for joining us at the first Friday of APGO Faculty Development 2022. I'm Laura Bacher-Lind, and I'm coming to you from Boston, where I am at Tufts University School of Medicine. And then my co-presenter, I will let her introduce herself.
Yeah, it's still morning for me. I'm here on the West Coast. I am Sarah Whetstone. I am the residency program director at UCSF, and privileged to be here with you all this morning / afternoon.
And Sarah and I, not only do we represent different coasts, but we also represent different aspects of the UME-GME transition. So I am a clerkship director, where I was a clerkship director for 10 years and then recently became a dean of education. So we've got both aspects of education covered too. So we're talking to you this afternoon / morning about anti-racist assessment and strategies to root out inequity in assessment and grading. We do not have any disclosures or conflicts of interest to share this morning. And our learning objectives, we hope through the course of this session to review data on bias in grading and assessment that underrepresented in medicine learners experience. Also recognize how bias influences common methods that we use as educators to assess our learners. And then ultimately to identify several strategies that we can use to more equitably evaluate our learners. So it's important to recognize that medical education is associated with high stakes, frequent evaluations of learners. So you can see here graphically, we have a few different ways that we evaluate our learners, whether it's taking standardized exams. We also examine and have quizzes multiple places throughout the medical curriculum. Letters of assessment, narrative feedback is a common way that we evaluate our learners throughout the medical education spectrum. And a lot of that is based on bedside interactions with our learners. So in the clinic, in the operating room, on labor and delivery, and all of those touch points with our learners, as well as all of the ways that we then put down our feedback on paper in evaluation is all a potential area where bias can be introduced. And this should come as no surprise, but we have to recognize that medical educators, whether it's faculty working in the clinic, whether it's us as the kind of meta evaluators, the clerkship directors, the program directors, we're human and humans are biased. So we have to recognize that at all of these touch points, including in ourselves as we generate narrative feedback, write letters of recommendation, that we have to be aware of the bias that we are bringing to the table and that our evaluators bring to the table when they're interacting with students and evaluating our students. Where and how is it that humans are biased? We could have a whole course on this, to be honest. But in summary, you've probably heard of kind of fast thinking and slow thinking. Daniel Hahnemann's work on the cognitive aspects of how bias can be introduced. And that really goes to these two icons here, the limits on the mind's attention, the fact that we do rely on these heuristics, these mental shortcuts, and sometimes make assumptions that are innate, that we're not aware of. And that is where bias can be introduced. There's also individual motivations, social pressure. So we know that residents talk. We talk to our colleagues, and sometimes there can be pressures to perceive students a certain way, or to pick up on something that others have picked up on that may not actually have been your original assessment of a learner, but it can influence your subsequent thinking about that learner. And we also know that our emotions play a role. In the 10 years that I was a clerkship director, I did come to appreciate the role of my emotions in how I evaluated my learners. And I made sure that I never did my formative feedback. I never did the grading unless I was feeling in a good place emotionally. If I was cranky or stressed or tired, I do think that I recognized that it would sometimes influence how I would review it and think about a student. And so being aware of emotions and how that plays a role is also important. So this is a fishbone analysis. This was published in Clinical Teacher in 2020. And this is a really interesting study that was done. So the authors had done a mixed method study that included focus groups of learners, of medical students at UCSF. And what they did in these focus groups, and there were also surveys that were a component of this study, was interview over 200 different medical students, both underrepresented in medicine as well as not, to see where they were experiencing stress and bias in their clinical settings. And what you can see here, it's a bit of a complicated diagram, but it's worth kind of taking the time to go through here. Is that the areas here, and you all can see my cursor, correct? My little arrow? Yeah, okay. So the darker boxes here are variables that came out of the focus groups and came out of the surveys that affected all students. Those in the lighter gray boxes were factors that disproportionately affected students that were underrepresented in medicine. And they're broken down into 4 categories, some that are personal or interpersonal, and others that are cultural or structural, and then subsequently broken down that were intrinsic to the student, and then also that were more intrinsic to the faculty or the rater. And what you can see here is that students, areas, there's a lot of variability in our students. We all know that. There's varied interest, competency, skills, effort that our students invest. However, the students that were underrepresented in medicine felt more the additional pressures of susceptibility to stereotype threat, of being exposed to microaggressions and racism in the clinical learning environment, having lower social capital and a lower sense of belonging compared to the non-underrepresented in medicine students. When we look at the rater, the faculty member aspect, we also know that not all faculty evaluate the same. We've got our doves and our hawks. Other faculty are really engaged educators. So others are more peripheral, and that affected all students. However, residents and faculty were also noted to, of course, themselves be vulnerable to unconscious bias, to committing those microaggressions that the students were experiencing in clinical learning settings. When we look down at the cultural and structural components, of course, working on teams in OB-GYN, we are frequently changing teams, and our students do struggle sometimes to adapt to that. However, the underrepresented medicine students also felt that there were differential patient assignments that were sometimes given to underrepresented medicine students. There were also healthcare inequities. And moving over to the school policies and school procedures domain, there's also always grade disputes. Anyone who's in undergraduate medical education knows this. Grade appeals, the delegation of grading, how grading is conducted within a department. Yet students who were underrepresented in medicine also had to contend with bias from normative versus criterion-based grading, weighting of exam scores. Some courses, some clerkships still use exam scores as a threshold at which you have to achieve a certain number in order to earn an honors, or it is heavily weighted in the final grade. And those are additional burdens that the underrepresented in medicine students experienced that negatively impacted their assessment. And cumulatively, when we look at this over time and over courses and over grades, our underrepresented in medicine learners will cumulatively earn less honors, will achieve fewer awards. And that, of course, has further downstream impacts as to potentially getting less competitive residency programs or impacting the career that they choose to pursue in the first place. And so this is really important, for pathway, used to be known as pipeline concepts, but the pathway towards having a improved equity and diversity in our field really goes back to this fishbone diagram. So where do, we talked about how, and we talked about from student experiences, where bias comes into play. And for the next few slides, I wanted to talk about, as medical educators, where we should be cognizant that we can potentially be introducing bias into assessment. So student narratives is one of them. So this is data from Ross et al. And they looked at the medical student performance evaluation, the MSPE, which, as you probably know, all of those narrative evaluations that students get from clerkships feed into the dean's letter, essentially, and then get sent to the residency application. So this is from Yale. What these researchers had done, they went through all of the applications to 16 different programs within Yale. It encompassed over 6,000 students, and did a textual analysis of all of the MSPEs from those over 6,000 applications. And what they found, they divvied up the adjectives that were used in these MSPEs and classified them as exceptional, best, outstanding, bright, or competent, with competent being, of course, sometimes code for maybe an underperforming student. And so the Black students were the referent group here. You can see that white students statistically significantly were much more likely to fall into the upper category, to be considered exceptional candidates and to be having exceptional type words used to describe those applicants. Whereas if we look down at the competent, the lowest category, again, the Black students were the reference here, and the white students were significantly less likely to have the types of words used about them in their MSPE that are kind of reserved or hedging words that are kind of code to suggest this is a student that might be underperforming. Letters of recommendation. So these are similar to the MSPEs and similar to the end of clerkship evaluations. But this table here is from that same Ross article. And this is from the University of Arizona. It's on their website. As far as making sure that when we're writing these letters of recommendation, whether it's for a summer opportunity, whether it's for residency application, that we are cognizant to be using words that are going to be most helpful to that candidate while still representing that candidate, and not unknowingly introducing bias. Some of these this is for the Commission on the Status of Women, so some of these are gendered terms, but it's important. These are a really helpful list here of powerful adjectives that can be and should be used if appropriate, because they are better descriptors and it will help students who really are in that excellent and exceptional domain to be perceived as such. Also, grading and formative evaluation. So I talked earlier about how exams do have inherent bias in them. We also know that something like AOA status, a lot of medical schools, including Tufts, have put a hold on student election to AOA because of the bias that has been noted to be pervasive throughout AOA awardees. And so the Boatwright article really is probably the most powerful that speaks to some of the bias in AOA selection. What this study looked at, and it's particularly fascinating if you look at the adjusted and the fully adjusted data. So this is a study of over 4,600 students that were also applying to a single residency program. They represented over 120 medical schools. And they looked through all of these applicants to say who was elected to AOA and who was not, looked at their race, and also looked at a whole bunch of other proxies for AOA selection, including Gold Humanism Award recipient, having received one of those, leadership, what percentile of leadership activities they fell into, as well as community service hours. For the fully adjusted model, the researchers also looked at USMLE scores, whether the student had another degree, including a master's degree or a PhD, and also looked at their research publications. And what you can see in this study, the white students were the referent. You can see that Black students in the fully adjusted model, I lost my cursor, there it is, had significantly lower rate of being elected to AOA, even in a fully adjusted model. And that was held true even across the board. And the white students in comparison were much more likely to be elected to AOA. Sadly, and I think perhaps most disturbingly, is that this study also looked over time. And if you go back to 1989, this is the data from 1989, here's the data from 2015 when this study was done. You can see that the proportion of students that were matriculated into medical school that were white dropped. There was increasing diversity over time. The Black students didn't change, 5.4% to 5.8%, so not meaningfully different over all of that time. And disturbingly, what you can see is that election to AOA in 1989, despite equal prevalence of Black students, 1.4% of students in AOA were Black versus 0.7. So the diversity in AOA actually decreased substantially during these 25 years compared to, despite the increasing diversity otherwise in medical school. And not surprisingly, you can also see that the proportion of people that were in AOA that were white dropped, but that was offset because of an increase in Hispanic and Asian and Pacific Islanders. So certainly a lot of bias that exists in the AOA domain. The learning environment ultimately is incredibly important. So that's another area where bias does commonly occur. This was a survey study. They sent this survey out to over 200 to many students. There were over 200 responses to 3 national student listservs: the Student SNMA, which is the Student National Medical Association, the LMSA, which is the Latino Medical Student Association, and the APA MSA, which is the Asian Pacific American Student Medical Association. And so from those 3 listservs, they sent out the survey, got over 200 responses, and looked, not everybody in those listservs, of course, is underrepresented. So did ask for that information, and then stratified by underrepresented in medicine versus not. And you can see there is substantially higher reports of being mistaken for a service worker or somebody to, food service worker or environmental services, being offended by comments about one's race or mistaken for a student of another race or of the same race, I'm sorry, asked to serve as a spokesperson for one's race, witnessing, microaggressions, being ignored because of one's race. All of those were substantially higher, reported as higher in students who were underrepresented in medicine. And then when we looked at the impact of those, so the top items here are all about experiencing those microaggressions. The bottom ones are about the impact of those microaggressions. And again, not surprisingly, there was a much higher burden of microaggressions negatively impacting learning, making one question one's belonging in the medical field. And this ties in directly to that fishbone diagram that I showed you before, as far as the impact of underrepresented medicine learners in an environment that is not inclusive. So why does having an inclusive learning environment matter? So this is a conceptual diagram here that shows this idea that learners need to be psychologically safe in order to be comfortable, and ideally in order to learn. Performance accountability, this is more of a high stakes. If something doesn't matter, it's hard to get stressed. It's also not a challenge, and so learning tends not to happen. But in a higher stakes environment like medical school, or like a clinical learning environment where the stakes are higher, the blue and maroon categories are what we're looking at. So if we are putting our learners in a clinical learning environment that is not safe, where learners feel unable to put themselves out there, to present a patient, to take a stab at a differential diagnosis, to get their hands on a needle driver, they're going to feel a lot of anxiety and stress. Whereas if they're feeling psychologically safe, if it's okay to not be 100% correct, if they know that they won't be mocked or belittled or have to deal with stereotype threat, then there will be a greater chance of learning in that safer learning environment. And we also know increasingly that the learning environment is incredibly important for multiple outcomes, one of which is well-being. Dr. Katz mentioned this morning in her plenary session, but about the high rate of burnout and depression in our field. And I'm excited to know that there's going to be a session on this about physician suicide coming up in the CAM meeting, because it's real. And we also know that there is an association between having a more stressful learning environment and higher rates of burnout and depression. And as it is, our third-year students have up to 80% of them will report burnout, and about 30% over depression. This is towards the end of the third year. And that, again, is more common in learning environments that are less safe. We also know that when physicians train in environments where they feel psychologically safe, where they are able to push themselves and not fear belittlement or rejection, they go on to practice similarly. And there's actually improved health outcomes for their patients. And patients do report when physicians look back at their medical education or their residency training and assess kind of how psychologically safe were they. People who trained in more positive learning environments, safer learning environments, those patients actually reported had higher ratings of their physicians. So in a world where we're looking at improving our health outcomes of our patients, having a positive learning environment is really crucial for the long-term development of our learners.
Thanks, Laura. It's always very sobering to hear those realities about sort of learning environments and outcomes about assessment. We're going to sort of switch to the sort of more interactive part of our talk, and really hoping to sort of think about how we disrupt these sort of disturbing trends around inequities in assessment of our learners, whether at the UME or GME level. We were going to use the analogy of the gardener's tale by Dr. Kamara Jones. And, you know, I never like to repeat things that people have already heard. So if you can use a thumbs up sign, please indicate if you are familiar with her allegory of the gardener's tale to explain sort of the different levels of racism. So I see about 3 individuals who have demonstrated that. Does anyone wish to share, or I'm happy to summarize some of the sort of key parts of it for the group. It's okay. I also have shyness over Zoom and speaking out loud. So I'll summarize sort of the key parts of it. So this is an allegory that Dr. Kamara Jones has developed years ago, which really was to describe the different levels of racism, including institutionalized or structural racism, personally mediated racism, and internalized racism. And her allegory sort of starts where she talks about how she and her husband bought a home in Baltimore, and they were interested in planting flowers, and they found sort of 2 flower pots or beds for the flowers, and one had sort of this old rocky soil that had been there, she presumed, for a long time. And the other bed was empty, and so she and her partner, you know, bought soil, which now is probably organic, you know, beautifully rich nutrient soil to plant these flowers. And she talks about having sort of red and pink flowers, which you can see depicted on the screen. And she suggested that she liked red flowers better. And so this idea that like she liked the red flowers better, so that she was also going to provide the red flowers a better environment. And so she planted the red flowers in this flower bed with this nutrient rich, fertile soil, and then planted the pink flowers in the sort of old rocky soil. And then over time, you know, the red flowers grew numerous, brilliant, like robust in comparison to the pink flowers. which did not grow so well. And you can see sort of the differences in the slide, these gorgeous red flowers and these sort of pathetic, less robust pink flowers, which seem sort of sad in their flower pot. And so then over time, how this sort of performance of these flowers reinforced her notion of which is better. She was right to favor the red flowers because the red flowers actually did better and bloom better and are more sturdy flowers in comparison to the pink flowers. And she talks about and she carries out this sort of narrative to explain all these different levels of racism. And we are really sort of interested in thinking about the soil and that sort of environment in which we find our learners find themselves and around the assessments that we use of them in those environments. And really with the idea of how do we as educators really enrich that environment so that all learners can succeed. Laura, if you could go to the next slide, please. And so and I think we have enough for breakout rooms. And so what we're going to do is spend about 10-15 minutes in breakout rooms, really reflecting on how bias in evaluation impacts learners, and then what we can do as educators to hopefully disrupt that bias. And so in your breakout session, and we hope that you'll stay. I know many times people see breakout sessions and leave, but we really are hoping that you will stay and be engaged in this conversation. We'd like you to look at one of the following tools and really reflect how bias sort of is innate in this form of assessment, and also how we introduce it by how we use it in our different settings. And so one group will look at letters of recommendation. This can include individual letters of recommendation, the chair's letter, our new form called the SLO or standard letter of evaluation. The second group will look at internal evaluation forms. These are the things that you use in your clerkships or resident rotations to provide sort of grades or assessments for learners, and then the shelf exam. And so we hope that you in your group will sort of think about how bias exists, is perpetuated, is reflected in your sort of local environments or how you've seen it for learners. And then after you have that discussion, we want you to think, no problem. We want you to think of one strategy where you are going to sort of enrich that soil, nourish that soil, really create the sort of space for all learners to thrive and succeed, especially from the stance of an evaluation and assessment.
And I am putting this into the chat, so when we go to our small groups, you can still see which tool you're assigned, and also remember what your tasks are. So I'm going to send you off into your groups. Stay tuned.
For letter writers in general, we also talked about as students are comfortable in their learning environment. There may be some, bias in the selection of who they do to complete their letters of recommendation, although we understand definitely that these internal letters have the same principles. And then we spent a bit of time talking about our strategies, including training and reassessment of the learning environment. We spoke about faculty development to facilitate change, especially as we are thinking about the evaluation process, and student reporting when there's a concern regarding their evaluation. So several institutions have, we call it a kudos and concern box in my institution, but how students themselves can elevate concerns about their own internal evaluations. We spoke about providing tools for faculty. Dr. Clay mentioned at her institution, they have assessment cards or cheat sheets within a link for faculty so that they can use appropriate language, especially when they're doing their evaluations, which we thought was very excellent. And we also debated whether numbered evaluations versus narratives were better or worse, still is debatable, as well as the impact of the pass-fail grading system in the evaluation process, really focusing on the need for formative feedback and competencies and evaluations that really reflect performance and capability. So I think a lot of room for FDS, faculty development, in writing an appropriate evaluation. Did I capture everything, guys? If not, please add.
I think you got it all. I couldn't find, it's not available in our faculty folder on OneDrive yet. So if I find it, I'll put it into the resources during next Friday's session.
That would be great. Thank you, Jansara.
Thank you.
And it's interesting because I feel like this conversation leans very much on the conversation we just had regarding shelf exam scores and the holistic review. Because in order to have this wonderful team that you've assembled, I think you said University of Colorado, Christine, where you have all of this invested time in carefully culling through each application, we need to have reliable, unbiased evaluations of our students if we're going to use that to supplant that step. Step 1 score or even shelf exam scores. So we need to kind of do those two things in tandem.
Yeah, so we did talk a little bit about how there probably is going to be maybe elevation in the level of bias that we're seeing as we transition to try to be more, evaluate more formative feedback, as some people will still be using some of that older knowledge and older systems, and some people will have moved on to this more competency base, which sometimes across as cold, but really what you're saying is I'm getting at the competency and not who the person necessarily is. And I do think that there's space for talking about interpersonal skills, but not necessarily personality in some of the feedback that we give.
Absolutely.
I mean, I think that the hard part is that it seems like the bias is so pervasive across the entire application for our students. I mean, it's in their assessment, although I do appreciate the schools that will say this is their clinical grade, this is their clinical grade with shelf. So you can at least put that aside. But, the language is frequently the same. The letters of recommendation are written in such a way by different people. And when you start reading them, it's hard to not notice it once you start paying attention to it.
Yeah. And I think the ultimate question, and I think this goes to sort of the challenge, is I think many of our evaluation modes and ultimately have tried to really rank and order students. You're the best, you're in the top 5, you're in the top 20, you're in the bottom 5 to help discern like who people would want to recruit. And so the sort of paradox of that is if you're trying for these normative assessments, you're never going to suggest that everyone can achieve. You will never get to equity because it will always be that someone's got to be better than somebody else. And so I think the ultimate question is it the role of medical students to like order their students, rank their students, or just to certify that they have successfully achieved the competencies? And then it's the responsibility of residency programs or whatever people choose to do after to assess sort of who would be best to thrive in that environment, separate from sort of this rank.
Well, and I think it would help, the medical schools to say, these are the things that this person is good at, because I know what type of resident succeeds at my program. And so then I could take their attributes and match my attributes of the program and put them together, because I don't, we have a very busy clinical service. We don't have a lot of support for research. So I don't need a lot of researchers. I need a lot of people who have, done a lot of clinical work. And so, and that might not match what you all are doing at UCSF. And so, that would help too. They're like attributes.
Yeah, very much so. I think those things are coming down the pipeline. Camille, you're going to say something?
I was just going to say, I think we just have to speak to being more qualitative in our evaluation. We as academicians or people in academia don't see as much value for qualitative work and qualitative assessments. We're very focused on quantitative numbers, grades, MCATs, etc. So it's difficult to make that transition to qualitative type evaluations, research, etc. So that may be a culture shift, which is maybe beyond this group, but I think very important points that Christine and others have made.
Yeah, absolutely. And really appreciate the engagement and investment. It seems as if you all are thinking about this work very deeply and doing some really amazing and innovative strategies. We were going to close with a few slides, which I'm not sure that we'll have time for, which really just sort of, I think, summarize many of the points you all have made around sort of like, what does it mean to have sort of equity in assessment? This is a definition that the Dean of UCSF has provided. And it's really when everyone has equitable opportunities to learn, to be evaluated, to be coached, to be graded, advanced, graduated, and be selected for subsequent opportunities based on their achievements that predict future success in medicine, and that neither their learning experiences nor assessments are influenced by structural or interpersonal bias related to personal or social characteristics. And so this is sort of like the grand theme. And so the idea is that like equitable systems and programs for learning and assessment have sort of three major components. One that's really on coaching, like how do you assess to help people grow and learn? Being very explicit about your criteria, making sure you prepare both faculty, supervisors, learners, that you have many strategies for frequent and actionable feedback. That grading is, you know, there has to be some sort of form of assessment of learning to confirm that people have learned what they are supposed to learn and gain the skills that they do. But that summative decisions are always based on multiple observations over many contexts with diversity of patients and settings. And so this really sort of deviates from the idea that one test would determine outcomes of grades or for residency decisions. And that summative decisions are really made by committees of diverse individuals, that again, these decisions are not held by one person alone. And then environments are really where learners are like learn and like making sure that we address all the threats to equitable learning for all. And then these are just some pearls for learner assessment. It's really like making sure we build educational alliances, that we observe behaviors in many contexts, that we really transition to competency-based, and that we also celebrate growth. You know, it's not just that you're excellent when you start, but it's that you have shown growth, because this is something that we're all going to need for the successful practice of medicine in the current era. And then these were just some sort of tips about narrative evaluations and thinking about how you implement these at your institutions. Like there's consistent length, like all evaluations are 5 to 6 sentences. You're using action words. You highlight contributions. What do people bring to learning, to care teams, to patients? And then there's a process by which those are reviewed to sort of avoid unintended stereotypes. And really like the goal is to avoid adjectives and muted language and comments about personal life. And so as we leave, I'll just leave these with you to think about in terms of like what your institution is doing around equity and assessment and grading. What are you doing around tools that have been shown to be harmful and inequitable? And what can you do sort of immediately? So hopefully in the 1 or 2 minutes after this session, you can write down one step you will take at your institution, but then also how do you assess your own progress in achieving equity and assessment? So I really appreciate everyone being here, your engagement, and look forward to this continued work.
Thank you to our speakers. Thank you, Sarah and Laura. That was awesome. I feel like your slide deck was probably available in our handout section. I'm so sorry I didn't go back to Huva and see. But then also, yeah, and then I would also just say that we might want to just continue discussions on the actual community board. So don't hesitate to drop some questions or thoughts there too. Thanks, everybody.
Thank you, everyone. Have a great day.